For decades, we've been told that confusion and memory problems in older adults automatically signal the beginning of dementia. But what if I told you that millions of seniors are being misdiagnosed, and that what looks like Alzheimer's might actually be something completely treatable? Today, I want to share with you a critical discovery that could change everything you think you know about cognitive decline in later life. There's a specific type of depression that masquerades so convincingly as dementia that even experienced doctors miss it. And the tragic part? While families prepare for the inevitable decline, the real culprit goes untreated. The confusion starts because late-life depression doesn't look like the depression we typically imagine. There's no obvious sadness, no visible tears, no complaints about feeling down. Instead, it presents as what researchers call pseudodementia, a condition so convincing in its mimicry that it can fool neurologists, psychiatrists, and families for months or even years. The person becomes forgetful, struggles with decision-making, appears confused about familiar tasks, and may even seem disoriented about time and place. Every symptom screams dementia, but the brain scans show minimal changes, and something deeper is actually happening. The problem begins with how depression manifests differently as we age. In younger people, depression typically presents with clear emotional symptoms, persistent sadness, crying spells, verbal expressions of hopelessness. But after age 65, depression often wears a mask. Instead of saying they feel sad, older adults might complain of fatigue, loss of appetite, or difficulty concentrating. They might withdraw from social activities, not because they're sad, but because thinking feels too difficult. Family members interpret these changes as normal aging or early dementia, missing the underlying depression entirely. What makes this particularly insidious is that late-life depression actually impairs cognitive function in ways that mirror dementia. The depressed brain struggles with what neuroscientists call executive function, the mental processes that include working memory, flexible thinking, and self-control. When depression affects these systems, the person genuinely cannot remember recent conversations, struggles to follow complex instructions, or becomes confused about familiar routines. They're not faking these symptoms, and they're not imagining them. The depression is literally interfering with their brain's ability to process information effectively. The biological mechanism behind this involves stress hormones, particularly cortisol. Chronic depression keeps cortisol levels elevated, and this sustained stress hormone exposure damages the hippocampus, the brain region crucial for forming new memories. Additionally, depression reduces the production of brain-derived neurotrophic factor, a protein essential for maintaining healthy neural connections. As these biological changes accumulate, cognitive symptoms become more pronounced, creating a perfect storm that looks exactly like early-stage dementia. One of the most distinctive features of depression-related cognitive impairment is its pattern of onset. True dementia typically develops gradually, with family members noticing subtle changes over months or years. Depression-induced cognitive problems often appear more suddenly, sometimes triggered by a specific life event, like the death of a spouse, a major illness, or a significant life change like moving to assisted living. The person might go from functioning normally to appearing cognitively impaired within weeks or a few months, rather than the gradual decline typical of Alzheimer's disease. The testing differences provide crucial clues for accurate diagnosis. People with dementia typically perform consistently poorly on cognitive tests, showing similar impairments across different types of mental tasks. Those with depression-induced cognitive problems show a different pattern called variable performance. They might struggle significantly with tasks requiring concentration and mental effort, but perform normally on tests of general knowledge or overlearned skills. They might also show what psychologists call negative response bias, frequently saying, "I don't know," even when they actually do know the answer, reflecting their lack of confidence rather than true memory loss. Another telling difference lies in the person's awareness of their cognitive problems. People in early-stage dementia often have limited insight into their cognitive changes, or may deny problems that are obvious to family members. In contrast, those with depression-related cognitive impairment are typically very aware of their mental difficulties and often express significant distress about them. They might say things like, "I used to be so sharp, but now I can't remember anything," or "My brain just doesn't work like it used to." This heightened awareness and distress about cognitive changes actually points toward depression rather than dementia. The sleep connection provides another important diagnostic clue. While both conditions can disrupt sleep, the patterns differ significantly. Dementia-related sleep problems often involve confusion about day and night, wandering, or agitation during evening hours. Depression-related sleep issues typically follow a more classic pattern: difficulty falling asleep, frequent night wakings, or early morning awakening with inability to return to sleep. The depressed person might spend hours lying awake worrying or ruminating, which further impairs their cognitive function the next day. Physical symptoms offer additional insight into the true diagnosis. Depression in seniors often manifests with unexplained physical complaints, chronic pain, digestive issues, headaches, or a general sense of feeling unwell. These somatic symptoms rarely accompany early-stage dementia, but are common in late-life depression. The person might visit multiple doctors, seeking explanations for their physical discomfort, while the underlying depression goes unrecognized. The response to routine disruption also differs between the two conditions. People with dementia often become more confused and agitated when their regular routines are disrupted, such as during travel or hospital stays. Those with depression-induced cognitive impairment might actually perform better in structured environments or when given clear, simple instructions. They retain the ability to learn new information when their depression is properly managed, whereas true dementia involves progressive loss of learning capacity. Family dynamics play a crucial role in both diagnosis and treatment. Depression in seniors is often triggered or worsened by social isolation, grief, or feelings of being a burden to family members. Well-meaning relatives might inadvertently reinforce the cognitive symptoms by taking over tasks the person previously handled independently. When family members assume the person can no longer manage their finances, medications, or household tasks due to apparent cognitive decline, the resulting loss of autonomy can deepen the depression and worsen the cognitive symptoms. The medication factor cannot be overlooked in this diagnostic puzzle. Many seniors take multiple medications, and certain combinations can contribute to both depression and cognitive impairment. Some blood pressure medications, sleep aids, and pain medications can cause or worsen depressive symptoms while simultaneously affecting mental clarity. What appears to be dementia might actually be medication-induced cognitive impairment combined with depression, both of which could be resolved with careful medication review and adjustment. The good news is that depression-related cognitive impairment is highly treatable, and the cognitive improvements can be dramatic once appropriate treatment begins. Antidepressant medications, particularly those that affect both serotonin and norepinephrine, can restore cognitive function within weeks to months. Cognitive behavioral therapy, specifically designed for older adults, addresses both the depression and the negative thought patterns that contribute to cognitive symptoms. When depression lifts, the fog of cognitive impairment often lifts with it, sometimes so completely that family members describe getting their loved one back. Environmental interventions prove equally important in treatment success. Increasing social engagement, establishing regular routines, ensuring adequate nutrition, and addressing any underlying medical conditions all contribute to recovery. Light therapy can be particularly effective for seniors whose depression has seasonal components or who spend most of their time indoors. Regular exercise, even gentle activities like walking or stretching, helps combat both depression and cognitive symptoms by increasing blood flow to the brain and stimulating the production of mood-enhancing neurotransmitters. The timing of intervention makes a significant difference in outcomes. The sooner depression is recognized and treated, the more likely it is that cognitive function will return to normal levels. However, if depression-induced cognitive impairment goes untreated for extended periods, it can potentially increase the risk of developing true dementia later. Chronic depression may accelerate actual brain aging, making early recognition and treatment even more critical. Support for family members becomes essential throughout this process. Learning to distinguish between depression-related cognitive changes and true dementia helps families respond appropriately to their loved ones' needs. Rather than taking over all decision-making, families can provide gentle encouragement while allowing the person to maintain as much independence as possible. Understanding that cognitive symptoms stem from treatable depression rather than irreversible dementia can transform the family's entire approach to caregiving. The diagnostic process itself requires patience and expertise. Mental health professionals experienced in geriatric care use specialized assessment tools that can differentiate between depression, dementia, and the combination of both conditions that sometimes occurs. Neuropsychological testing can reveal the specific patterns of cognitive strengths and weaknesses that point toward depression rather than dementia. Brain imaging may be used to rule out other causes of cognitive impairment, though it's important to note that normal brain scans don't rule out early dementia, nor do they confirm depression. Prevention strategies focus on maintaining mental health resilience as we age. Staying socially connected, engaging in meaningful activities, maintaining physical health, and addressing life transitions proactively all help prevent the development of late-life depression. Regular mental health checkups should become as routine as physical health screenings for older adults, particularly during major life transitions or health changes. The broader implications of this knowledge extend beyond individual families to healthcare systems and society's approach to aging. Too often, cognitive changes in seniors are dismissed as normal aging or immediately attributed to dementia without considering treatable causes like depression. Healthcare providers need better training in recognizing the subtle presentations of late-life depression, and families need education about when cognitive changes warrant professional evaluation. Recovery stories illuminate the profound difference accurate diagnosis can make. Seniors who were preparing for nursing home placement due to apparent dementia have returned to independent living after depression treatment. People who had stopped driving, managing finances, or participating in beloved hobbies have reclaimed these activities once their depression was properly addressed. Adult children who had begun grieving the loss of their parents' personality have discovered that person was still there, hidden beneath treatable depression. The key lies in maintaining hope and seeking professional evaluation when cognitive changes occur. While dementia remains a heartbreaking reality for many families, not every instance of memory loss or confusion in older adults represents irreversible brain disease. Sometimes, what looks like the end of mental sharpness is actually the beginning of a journey back to cognitive wellness. The message here isn't to ignore concerning cognitive changes or to assume they're always depression-related. Rather, it's to ensure that treatable causes like depression are thoroughly investigated before accepting a dementia diagnosis. The brain's capacity for recovery, even in later life, continues to surprise researchers and clinicians. When depression lifts, cognitive abilities that seemed permanently lost can return, relationships can be restored, and the person can reclaim their sense of self. Understanding that depression can masquerade as dementia offers hope, where there might otherwise be despair, treatment options where there might be resignation, and the possibility of recovery where there might be only decline. For the millions of seniors struggling with cognitive changes, this knowledge could be the key to reclaiming not just their mental sharpness, but their entire quality of life.